All right, so now we're going to begin our roundtable discussion on terminology, diagnostic labels, and their impact. The purpose of this discussion is to address the fact that there are currently many clinical names being used to describe this condition. Why is that the case? And why and how might this be a problem? What's the most accurate name to use? What's the current impact of this problem? And what would be the impact on the medical community settling on a single universal name? So to continue this discussion, or to start this discussion, we're going to have Dr. Selim Benbadis again, Dr. Ioannis Karakis, and Dr. Nicole Roberts and Dr. Ben Tolkin. So we'll also welcome members of the audience to contribute in discussing this using the Q&A chat feature. Who would like to begin?
Would be happy to begin if you would like.
Please, Dr. Benbadis, good to see you again.
Nice to see you too. It's nice to see my colleagues here. I'll start by saying that it is confusing. There are too many terms. There are terms that we would all agree are bad and should be abandoned because they have a negative connotation. We know what those are: pseudo seizures, very old term like hysterical or pseudo epilepsy, etc. So I think that's something we would all agree on. There are things that are a little bit more controversial. I can tell you that personally, I do not like functional seizures. I do not like the word functional, and I do not like the word seizures. And I will tell you why. Functional, I think, is too esoteric. We in the medical community know what we mean, but I submit that the average patient, the average layperson doesn't know what functional means. I think it's a euphemism to not use the word psychological or psychogenic. I am personally a big proponent that the P word, psychological, psychogenic, should be in there. We are asking these patients to see a psychologist and a psychiatrist and do psychotherapy. Why is it a problem to have the word psychological or psychogenic in there? That's the first issue. So I don't like terms like NES, for example, or NEAD, because as I said this morning, not everything that's not epileptic is psychogenic. These terms are just inaccurate. Second part of it is I don't like the word seizure because it's confusing to patients and families. If these are seizures, why should they not take seizure medications, which, by the way, anti-epileptic drugs now are officially called anti-seizure medicines. So if you go by that logic, they should be taking anti-seizure medicines. In the English language, the word seizure, whether we like it or not, in the English language, it implies an epileptic nature. I know some of my colleagues, including my friend Kurt, disagrees with me on this and would argue that seizure is a vague term, but that's just not true. We don't speak of seizure of asthma or seizures of gout. Seizure in the English language generally implies abnormal electrical activity in the brain. So I think it's a mistake to continue using that word. Attacks, events, episodes, spells, there are many other choices in the English language. So that was my spiel. I like neither functional nor seizures. I think that'll start the discussion.
No, I think that's going to definitely start the discussion. Very, very, very passionate. Very passionate. Does anyone have something to add or to, I guess,
to challenge?
Yeah, challenge. Perfect.
So I have some thoughts on this. So you know, as Dr. Benbadis says that this is, you know, a very controversial area, and I just to be clear, I think the single most important thing is that we, as a field, as a community of patients, families, advocates, and clinicians, agree on some one term. And frankly, I think almost any of the terms under debate would be better than no single unified term, because I think not having a single unified term does a lot of harm to patients who are confused. It makes it difficult for physicians and other clinicians who don't specialize in this field to keep up with the research. It makes it difficult for clinicians and researchers who do specialize in this field to conduct research, because it's hard to search the literature. It's hard to describe what what research you're focusing on, and to connect studies of related disorders, because there are multiple different terms used by different researchers. So I think there are a lot of problems associated with the current state of uncertainty and confusion. And I think the most important problem there is the confusion to patients and families who are encountering this disorder for the first time and are having trouble researching online and researching in books and journals to understand what they're being diagnosed with, and to learn about it independently. I absolutely agree that there are certain terms that are clearly offensive and shouldn't be used, and that's been documented in surveys of both patients, family members, and clinicians. As was raised, I think like pseudo seizure, hysteria, those terms are appropriately avoided by most clinicians, although you will see some clinicians using those terms even now. I think we're, as a medical field, we're moving well away from those, and I think that's entirely appropriate. In terms of, so right now, the big debate tends to be between the term psychogenic non-epileptic seizure, which is the most commonly used term. If you look on Google, if you look on PubMed, psychogenic non-epileptic seizure is by far the most commonly used term.
Well, yeah, it was the one accepted for the longest time until recently there was some change.
Yeah. And the motivation for that change has been that there are now several surveys of patients in particular where patients express discomfort with the term psychogenic. And there are some surveys where the dissatisfaction and discomfort with psychogenic is nearly as high as the discomfort with the term pseudo seizure. And so I think that has motivated a number of clinicians and researchers in the area to seriously consider other terms, such as functional, or in the United Kingdom, a lot of the researchers in this field are using the term dissociative seizures. And so there's been a lot of debate about this among clinicians and families and patients. One argument in favor of functional, and I do think there's some merit to this argument, and so this is a little bit of a challenge to Dr. Benbadis, is there's this broader category of functional neurological disorders, and there's a lot of research being done in the treatment and diagnosis and underlying causes of functional neurologic disorders. And I think many clinicians agree that functional seizures or attacks, whatever, or psychogenic non-epileptic seizures are one subtype of functional neurologic disorders, and are very closely related, in many cases co-occur. And so there may be a lot of benefit from linking the term for this subtype of psychogenic seizures or functional seizures to the broader category of functional neurologic disorders. And so that's an argument that many clinicians and researchers give for using the term functional seizure. I do agree with Dr. Benbadis that it is, it's a very esoteric term. It's not familiar to a lot of people, and it's not widely understood. There is this concept of there's this concept of a euphemism treadmill, right? Whereas terms that are linked to a stigmatized condition are used for that condition, the terms become stigmatized, and so they're abandoned. And so the argument is, well, that happened with pseudo seizure, and now it's happening with psychogenic seizure, and it's going to happen with the next term. And the real problem is the stigma that's associated with the condition and not the name. And you can switch the name as many times as you want, but as long as there's a lot of stigma associated with the disorder, the next name is going to become stigmatized as well. And so maybe that's an argument against switching away from psychogenic seizure to a new term such as functional seizure or functional neurologic disorder. The last thing I'll say is that as a seizure doctor, I'm very sympathetic to this concern about the use of the term seizure. I do agree that among 90% of physicians and among the general public, seizure is associated with hypersynchronized electrical discharges or epileptic seizures. As Dr. Benbadis mentioned, anti-seizure medication refers to medications that are used to treat epileptic seizures. And so I think I am concerned about keeping the term seizure.
Just to interrupt, sorry, there's a lot of questions in the chat about what the term functional means. And I agree it's problematic because you think, oh, you're functioning, you're doing
Making
well.
My point that it is confusing and too esoteric.
Yeah, but it has psychoanalytic roots, and then now it has more current. Can you just to clarify for folks what the field means by functional in this context?
Yeah, Ben, go ahead. You were on the way.
So
right, you almost said it, so that's why I'm deferring to you on that.
Sure. So functional in this setting, I think a lot of modern users would avoid the psychoanalytic roots and would focus on functional as a category of disorders where there is not a underlying neurological lesion, but rather there are symptoms that are functionally impairing and achieve a functional outcome similar to that produced by a neurologic lesion. So these are disorders that are currently widely termed psychogenic. Some advocates of the term functional note that functional does not necessarily imply a psychological etiology. And while 90% of patients with these disorders have an identifiable psychological etiology, there's approximately 10% where there is no such psychological etiology, and so functional may be preferable because it doesn't necessitate that psychological etiology. It simply indicates that there is a functional deficit similar to what would be caused by a neurologic lesion, but is not in fact caused by a neurologic lesion.
I just think it's a euphemism beating around the bush. It's medical jargon because we don't want to say that it's psychological. Personally, I see nothing wrong with the term psychological, especially when we ask patients to see a psychologist. I don't know why that's so difficult to accept. It's in the DSM, Manual of Psychiatric Disease, not functional diseases. I think personally, I think the word P, whether it's psychological, psychogenic, should be in the name.
And there's another point. So we've had great discussions about this in December. There was a What's in the Name panel and a paper coming out of it. And so for me, it helps to think about the origins of names for other conditions like PTSD that was shell shock and how that's evolved, or ADHD is attention deficit hyperactivity disorder. But before it was just ADD, and then they added the hyperactivity component to enrich it. So I have been brainstorming, and I think we're still somewhat early, but names such as emotion motor conversion, or not conversion, emotion motor disorder instead of conversion. And so if we can have a sense, because as another example, there's a disorder now, disruptive mood dysregulation disorder, and no one really quite knows what it means. But for kids who don't have ADHD, who don't have bipolar disorder, but are showing behavior and mood symptoms, it's this good catch-all for now, and it has specific criteria in the DSM. So that's just one devil's advocate perspective, that if there was something that was a more process-based name, maybe it would circumvent. It's psychological, but it's biopsychological.
So just a quick question. Is there some aspect of terminology that you all, because I understand that all doctors are definitely not going to agree, but we have such a small panel. Is there an aspect that you all would agree should be in the name?
Well, I've said mine, so others.
Well, I may be able to take that. I'm Ioannis Karakis. I'm at Emory University, and I would like to thank the organizers for the invitation and all the panelists who spoke before me. I think we have more to agree upon than to disagree, but trying to give an answer to your question, I'm not sure you will be able to agree on any of the terms that are already included at this point. And I will explain why. I think the terminology is a very, very important issue because it aligns with our tripartite mission, which is to provide consistent and high quality clinical care education to patients, families, our colleagues, the community, and set the groundwork for discovery without really agreeing on a term. It's kind of difficult to conduct meaningful research as well. And this perpetual debate about the terminology is predominantly, I think, the outcome of the prism through which the different people have approached the issue, because there are so many different stakeholders, neurologists, psychiatrists, and primary care providers, ED providers, patients, families, insurer managers, public health advocates, and agents. So depending on what angle you are using, you are going to have a different point of view. I think the International League Against Epilepsy made a sincere effort about a decade ago through a task force to kind of resolve this issue. And the three main axes which were used to create a common terminology was to have a term that is easily acceptable by patients and their families, by clinicians of all subspecialties. And it speaks about the nature of the problem, describes the problem and the etiology, and gives some sort of a guidance as to what treatment needs to be implicated. And that's why I think PNES prevailed, which was, I think, the first initial step to get rid of prior very offensive terms that were in place, like pseudo seizures or hysteric seizures and so forth. But then as things evolved in the past 5 to 10 years, every single aspect of this acronym was criticized. So for psychogenic, as people already spoke about, the term psycho is frequently misinterpreted by the public. It also creates a dualistic view about neurology and psychiatry, and there are two different complete entities. For seizures, we have debate that Dr. Benbadis said that seizures should be reserved only for epileptic seizures and nothing else. And as an acronym as a whole, even the pronunciation of the acronym itself was having some phallic connotation. So there are all sorts of arguments that people have identified with regards to PNES as an acronym. And in reply to that, the terms that were already discussed came into play. So functional seizures was one of them because it's considered to be less offensive, and it doesn't really explain the underlying pathophysiology that we don't fully understand yet, and it puts things in the right place of the DSM-4 and 5 nowadays, and other terms like non-epileptic attacks without the psychogenic on top of that, and dissociative seizures or conversion disorders. I personally feel that all the new terms that have been suggested, they don't adequately describe the phenomenology nor the etiology or presumed etiology of these dysfunctions. If it was me, I would consider them to be very opaque as terms and rather vacant. So contrary to the International League Against Epilepsy term, I don't feel that they portend to any substantial benefit from what we currently have. I can see the different viewpoints and I respect them. And I honestly don't think that we will settle that today or for the next few years. But to be honest, I think it's time to focus a little bit more on what can we do to understand this disorder and how can we treat it better than actually getting stuck so much on the terminology, despite the merits that nosography has on its own. As Dr. LaFrance has pointed out in the past, a lot of times what you tell the patient, what they understand may be completely different. So it all really depends not so much on the term that you try to use, but it depends on the way you convey the diagnosis.
Yes.
So if we manage to maintain a compassionate, consistent, longitudinal, multidisciplinary relationship with our patients, where we identify with their problem, we express compassion and empathy, and we stay next to them throughout the years, regardless whether you are a neurologist or a psychiatrist or a public health advocate, and try to help them throughout the process, I think that they're more likely to benefit regardless of what is the labeling of the disease that we provide to them. So my take-home message of the whole discussion is that although I totally respect the reason why you're going through this, and I see its merit, that what it matters is to focus on picking up a name and moving forward with the essence, which is essentially identifying the pathogenesis and the treatment of this disorder.
And very importantly, because I see it in the chat, and Dr. Roberts pointed it out, I see a lot of comments in the chat that if we put the name psychological, psychogenic in the term, then we get treated unfairly and badly by physicians in the ER and so forth. And unfortunately, that is true. But changing the name, as my idol, Dr. Lorna Myers, just responded in the chat, and I agree 100%, changing the name isn't going to change that. We need to change attitudes. That's very different from changing the name. I think the name psychological should be in there, and we need to educate the medical community, for example, that psychogenic seizures do not mean faking. We all know that here, but the chat is absolutely right. Unfortunately, a lot of ER physicians and nurses and non-specialists, when they hear psychological, they think faking. We need to fix that. Changing the name, as Dr. Myers just said, is not going to fix that.
And I think that's a great point.
Sorry about that, Dr. Roberts. Go ahead.
Well, I was just going to say quickly, I had never thought about it that way, that yes, if you have schizophrenia, there's the stigma. You know, if you have hallucinations, there's a stigma. But if you do, you do, and that's how it is. But at least you know what it is and how to treat it. I just hadn't thought of it in that direction. So yeah, go ahead.
Yeah, I would just like to add to what Dr. Benbadis said, is that on the one hand, you have the issue with the emergency room providers. On the other hand, you want them to really distinguish the epileptic from the non-epileptic seizures, because we have seen it tons of times when the confusion arises and people get intubated in the emergency room without any rhyme or reason, or in the outpatient setting, people continue to get anti-epileptic medications for no good reason either. So on the one hand, having the term psychogenic creates that discrimination that people are concerned about, but on the other hand, it can act protectively towards patients not to get treatments or diagnostic evaluations that they do not need. So it has to be in the term, in a clear way that functional does not really deliver.
As another kind of devil's advocate perspective that had occurred to me, and I think it was John Stone who mentioned it previously, is you could just give it a name of any kind, just to unify to the point earlier of something is better than nothing. You could crowdsource or something, have everyone chime in and vote on a term like the John Stone condition.
Well, that would be neutral. I kind of disagree, though, with saying that a bad term is better than no uniform term. A bad term is confusing and it has consequences. Like we just heard, people get intubated when they see the word seizures. They might get intubated in the ICU. They might receive IV phenytoin and so forth. So, I mean, I don't know if that happens often, but I'm not sure a bad term, a uniform bad term is better than no uniform term. I'm not sure about that. I don't like the term functional seizures. I don't talk to my patients and say, you have functional seizures. They don't know what that means. I use terms that I know people understand: psychological, stress-related, emotional. I think they understand what that means. Everybody has emotions. Everybody knows we get a stomach ache because of psychological factors sometimes, or a headache. So I think people understand that. Functional is esoteric. We physicians know what we mean. I don't think the community in general understands the word functional.
So for me personally, to Dr. Roberts' point, what about a non-specific name? Like she said, the stone condition or something like that. And that way it's limited to the definition, and therefore you've got a lot more space in which to explain it, as opposed to, 2, 3, 4 words or an acronym.
I don't like acronyms.
Sometimes there's a name. What we need is someone to donate millions of dollars to the cause, and then we'd have like a Lou Gehrig's disease, but it would be something, and then that would be the name. But then there's the genuine term under it.
The problem is that this is not a new or original condition. It's in the DSM. It's been around for centuries. Whether we don't like the terms in the DSM, the conversion disorder with seizures, for example, is the official term in the DSM. Why can't we use that? Although I don't like the word seizures again, but I'll compromise. I'll eliminate functional, keep the seizures. Nothing is going to be perfect, but we're trying to reinvent the wheel. This thing has been around for centuries under various names. It's not something new. And people who continue to advocate for NES and NAED or NEAD are missing the point that that is inaccurate. It is too global. Those disorders, yes, they're non-epileptic, but so are tics, TIAs, migraine, tremors. It's too inclusive. It doesn't have the psychological part. Why do you need to see a psychologist if it's non-epileptic and it's a syncope? You don't. Non-epileptic is not synonymous with functional or psychological. There are many things as neurologists that we see that are neither epileptic nor psychological. That those terms are just simply inaccurate. They are too broad.
And there could also be specifiers, like if you went with non-epileptic due to,
yes,
psychological due to,
exactly,
emotional.
Exactly. So functional is a subtype of non-epileptic. That's fine, but it's not synonymous. And many people want to use these terms synonymously. They're not. When we run an epilepsy monitoring unit, as you know, we capture a lot of episodes sometimes, and they are not epileptic sometimes, but they're not psychological. They're not functional. They are something else. TIAs, migraines, tics, tremors, dystonia, posturing. There's all kinds of things, sleep disorders, cataplexy, parasomnias. There are plenty of things that are non-epileptic, but are not this. So equating the two is just inaccurate.
I'm just seeing in the chat, there are questions about conversion disorder. And why is that not used? And I'll just say, so I think the reason, so if you look in DSM-5, the broad category of conversion disorder it is used along with functional neurologic disorder. I think the reason many clinicians and researchers have moved away from conversion disorder is that it has a psychoanalytic theoretical underpinning, right? And so it's implying that a specific psychological process, and there's quite a bit of debate about whether that psychological process in fact occurs in this disorder and in other psychiatric disorders. And so I think many folks have wanted to move to a term that doesn't imply a specific psychological mechanism that can't definitely be shown to be used in this disorder. So that's why people have moved away from conversion disorder with seizures, which is one of the terms you'll find in the DSM-5.
There are also comments about functional, meaning that it's non-anatomical, and I think, Ben, you mentioned that, and is not structural, and that is true, but we have many diseases in neurology in that sense that are non-functional, that are functional in the sense that if you do an autopsy and a brain analysis anatomically, they're normal. Narcolepsy, for example, and for that matter, primary generalized epilepsies or benign Rolandic epilepsy of children, those are functional in the sense that if you cut the brain in every possible way, you do not find a lesion. Migraine is another one. So again, functional is nebulous when it's trying to say psychological, but it doesn't. By the way, this debate would be much better in person.
With drinks.
Yes, thank you.
I was going to ask if everyone had their mimosas earlier this morning.
No. But later.
I think just as another point, when someone is getting a diagnostic label, it can be very helpful in terms of saying, oh, this describes me. This is what I have. But it also can be, this is who I am and that's it. And it neglects other identities or parts of themselves. So again, the label, the name that says what it is can be both good and bad. I've also used the example before of traumatic brain injury, where people think, oh, my brain is injured. And so then they start to have a lot of psychological issues of memory loss and cognitive impairments that actually are due to concerns about their memory or lack of sleep or anxiety versus TBI, if it's mild, usually recovers. So again, more considerations than answers.
I mean, I will say in my personal experience, you know, I've sort of used different terms throughout my training and practice. And I have never had patients express dissatisfaction with the term, as long as it's explained in an empathic and non-judgmental way. That particular aspect of it has never been a concern. And
agree.
So again, I'll sort of come back to my point. I really think like any of these terms, if used in a unified way, would be an improvement. I really worry about the fracturing of the field into different terms. I think it's confusing for patients, for families, for clinicians. You know, Dr. Benbadis says, well, but if we have a bad term that includes seizure, that could lead to harm to patients. But I would argue that what's really confusing to ER doctors is lack of understanding about the disorder. I think, and I think having multiple names contributes to that much more than having a slightly confusing name. I think the patients and clinicians and researchers would all be better served by a single term, whatever that term is. And you know, as Lorna Myers said, you know, and Dr. Karakis said, you know, I think we get overly invested in the debate about the terms, and I think the energy would be better invested in educating clinicians to be more empathic, educating the general public to try to reduce stigma, and in research, investigating the underlying etiology of the disorder, rather than having these ongoing debates about the terminology. And
I agree, and I too have not been impressed that people react badly to the terms. What they want is a good explanation, an empathic, compassionate delivery of the diagnosis, and clarification that psychological or psychogenic or functional does not mean faking. That's the biggest harmful misconception. And by the way, and I'm sure you guys can confirm this, every day I hear that confusion from nurses, from residents, from attendings, from the ER. When we say psychological, we know what we mean. They take from it faking, which of course is the biggest tragic misconception.
So to add to that, I have a question, which is, if education is one part of the answer, how do we go about resolving that with clinicians?
So I mean, I think there are a number of efforts underway. I'll just to speak to a couple of things. So first of all, I think having a patient advocacy organization like FND Hope is really important. I think that FND Hope has done some really amazing work just in bringing in highlighting the patient perspective, not only for patients but also for clinicians. There were a recent series of talks about the disorder run by the American Epilepsy Society and by the Functional Neurologic Disorder Society. And far and away, the highlight of those talks was the patient perspective brought by representatives of FND Hope. So I think having an organized advocacy instrument like FND Hope is very powerful in terms of educating clinicians as well as the general public. Alongside that, I think another thing that's helpful is having professional organizations such as the relatively new Functional Neurologic Disorder Society. So that's a group of clinicians and researchers who specialize in caring for and researching the underlying etiology of these disorders. So I think that's both of those are very important developments. I do think that there needs to be a greater focus from research funding organizations like NINDS, the National Institute of Neurologic Diseases and Stroke, in terms of providing funding for research on this. But I think that will come with advocacy by patients and families and by clinicians and researchers through organizations like FND Hope and the Functional Neurologic Disorder Society. Those are my quick thoughts on that matter.
It would also help, by the way, if our favorite mental health organization, the APAs, American Psychiatric and American Psychological Association, did a better job getting involved with this and educate professionals. I mean, it's basically, that should be their task. And as you may or may not know, if you go to their website, both APAs, psychological and psychiatric, there is very little. And up until recently, there was zero information on functional disorders, conversion disorder, etc. Now I believe there is little, but very little compared to things like PTSD, ADHD, depression, anxiety. There is so little. I've always been unhappy with those organizations. They basically hide from this category of diseases. I think they should be held accountable for not taking charge of this education we were all talking about, to EMS, to ER docs, to internists, to pediatricians, etc.
I was going to say a few of us are, oh, go ahead.
Go ahead.
A few of us are going to be launching a survey for providers to see what their training is, how much they know. I can say as a trained clinical psychologist from California, I didn't know about functional neurological disorders or non-epileptic seizures until I was already a faculty member. Like a few years ago when a neurologist colleague said, hey, you study emotion, maybe you can help work with some of our patients who we refer to psychology, and then the psychologists don't know what to do either. And so I think it really is, if we can, so as I and others publish more in mainstream psych journals like emotion and not just epilepsy and behavior, I think that will help. But I think when I submit papers to different journals, it is this fuzzy category of neurology, psychology. However, I will say now there is much more acceptance than there was even 10 years ago.
This kills me. I get every week emails from people I don't know, from everywhere, literally the world, saying that they went to a psychiatrist or psychologist and they were told, oh, he doesn't know about these things. He's never heard of them. It's in the DSM. How do they graduate? It's not in the manual of dermatology. It's not in the manual of oncology. It's in the DSM. It's amazing to me how many psychiatrists, more so than psychologists, can claim that they have never heard of this. And I hear that all the time. I went to the psychiatrist, they said, I've never heard of this. What do you mean? It's in the DSM.
And I think it's because it's this antiquated notion of, I can't feel my arm. Oh, I'm going to talk about my problems. Now I can feel my arm. And it's conversion and it's Freudian. And I think mainstream psychologists tried so hard, at least in the US, to move away from that and be more medically based, that anything that hints of that is a problem, which I disagree with. So it's excellent we're having these talks. Yeah.
So to reinforce that, I'd like to add that the education should start a little bit earlier as people get into medical school. I think the curriculum that they have to follow has to be revised to speak more on the interface between psychiatry and neurology. And further on, during residency, I think these functional neurological presentations should be incorporated in the ACGME requirements, which is the organization that essentially defines what type of residency training you get, regardless whether you are going to become a neurologist, a psychiatrist, an internist, a cardiologist, or any type of clinician who may be the first one coming across patients with PNES. And taking it back one step, I think the disadvantage of practicing in the US is the fact that you become so subspecialized, such an expert in your own field, that eventually you end up focusing so much on your own tree and losing the forest behind it. So I think regardless of what subspecialty you have, you need to be aware of different presentations of PNES and then refer the patients to the right clinician right away, but at the same token, know what kind of treatment path needs to be provided if they end up turning back to you down the road. That's holistic medicine, and it's something that we need to actively work on in every subspecialty down the road.
So just in terms of this issue of some psychiatrists, psychologists not being familiar with the disorder, and I will say there are also many neurologists and emergency medicine physicians who are not familiar with the disorder. So
But that's more excusable. That's not their specialty.
Well, I think all of these specialties should be familiar with the disorder and should have some understanding of the diagnostic process and the treatment process. I don't think we could, as a neurologist, I don't think it's fair to pin the blame entirely on psychiatrists and psychologists. I think we all have some responsibility here.
We do, but you can't have a psychologist or psychiatrist say, I've never heard of it. It'd be like you and me as a neurologist say, I've never heard of migraines. I mean, what is that?
Yeah, so I think many neurologists will show a remarkable lack of knowledge about the proper diagnosis and treatment of these disorders as well. So, I think we're all kind of at fault here. So, but I think one step we can take to remedy this situation is professional guidelines. So outside of medicine, people may not be aware of this, but a lot of medical practice is defined by and guided by evidence-based guidelines that are produced primarily by professional organizations. And a number of folks have been advocating for guidelines around functional neurologic disorders, psychogenic non-epileptic seizures for years. Up until recently, there has not been sufficiently high quality randomized trial evidence to base these kinds of guidelines on. But this has really been changing over the last 5 to 10 years, particularly in 2020, there was a publication of the CODES trial, which was a large randomized trial of cognitive behavioral therapy, specifically for psychogenic or dissociative or functional seizures, whatever you want to call them. And so I think for the first time, professional organizations are now seriously considering guidelines. And in fact, the American Academy of Neurology has an evidence-based guideline for the treatment of psychogenic or functional seizures sort of underway. Now, I think Dr. Benbadis points out that really the APA, both APAs should be on board with this. And this is going to be like a multi-year effort. This isn't going to be something that happens tomorrow or next month, but over the coming few years, I think it's going to be important for these different professional organizations to collaborate to produce guidelines regarding the treatment and diagnosis of these disorders so that there can be some consensus within the different medical specialties that need to be involved. Neurologists can't do this by themselves. Psychiatrists can't do this by themselves. There needs to be collaboration across specialties. And the foundation for that, I think, has to be evidence-based guidelines. And so I think that's sort of like the next step in my view.
So I've seen somewhere in the chat that someone was suggesting or curious about perhaps empathy training for clinicians. Do you think that do you think a lack of empathy is part of, I guess, of how people with functional seizures, for lack of a better term, get dismissed?
Yes, but the lack of empathy is related to ignorance and lack of education, and again, the assumption that psychological means faking. That's where the lack of empathy go. When you go to an ER and they're busy with stroke and head injuries and so forth, if they assume that when we say psychological we mean faking, yeah, they are not empathetic. That's related to the prior topics of education of EMS, ER docs, nurses, etc.
Okay, so just to add to that, is that something that you're obviously probably not 100% on, but I guess my counter to that is, from my understanding, a lot of like Black people who experience pain, they might convey to their doctors, I'm experiencing like this amount of pain, and for some reason their doctors don't believe it.
Yeah. I mean, I think there is room for training specifically on empathic communication. There are different types of communication modalities that have been shown to be more effective in caring for patients with psychogenic or functional seizures and other disorders. So, for example, motivational interviewing is a patient-centered communication technique that really focuses on hearing and reflecting the patient's words and helping to identify patients' reasons for behavioral health changes, and a lot of the training focuses on empathic and non-judgmental communication. And so I think there are actually evidence-based communication curricula that can be used for physicians, nurses, and other specialists, and I think can be helpful, even above and beyond education about the disorder itself. And I think that would be helpful for functional neurologic disorders and many other disorders, frankly. I think many physicians and other clinicians would benefit from some communication training, and that would, I think that is a part of the problem here, is the lack of communication training that occurs in medical school.
It's the empathy, the communication, and then also the cultural sensitivity, as Raymond mentioned. And yeah, Blacks are overdiagnosed with schizophrenia, or at least historically were underdiagnosed with depression. Girls were underdiagnosed with ADHD, and so there are all these gender biases and culture biases, and so also the health literacy of the person. I had a colleague who recently did a study looking at the language between patients and providers, and the language the physician used intersected with the health literacy and understanding of the client and their demographics to influence whether they understood and carried out a treatment plan. So we think about precision medicine in terms of the biology of it, but they're applying it also to the communication as well.
And I would add to that in order to educate somebody, in order to properly diagnose and treat somebody, you need to have a group of disorders under your radar and keep an open mind about them. So people not only need to know about functional and neurological disorders in general, but they also need to get out of their silos and understand that they are not dealing with just a group of diseases, they are dealing with a human, and address that in a multidisciplinary way, holistically.
All right, doctors, we're almost out of time, but I do want to ask, what would you recommend for someone who goes to the ER or who's with a clinician who doesn't seem privy? How would you recommend they communicate their symptoms, what they're experiencing, so that they can get directed to someone like you?
So, I think it's important to establish a long-term relationship with a clinician who has some knowledge of the field. I think bouncing around from ED to ED can be frankly dangerous and certainly not helpful. I think that my recommendation is to start before a moment of crisis to spend the time beforehand, seeking expert help. You can start with a seizure specialist, but you also want to be involving a psychiatrist and a psychotherapist, whether that's a psychologist or a social worker in your care team, and establishing that relationship long term. Once you have that in place, it's possible to, when you're in crisis, when you're in the ED, first to reach out to the folks who know you, who you have an ongoing relationship with. And second, if you're not able to immediately get in touch with them, and you do have to go to the emergency room, to ask your providers in the emergency room to reach out to your long-term health team. And unfortunately, you're going to run into some clinicians in the emergency room who may not be as receptive to things that you say, but they will often be more receptive to things that another clinician says. And so I think that can be a helpful strategy, getting them, the ED folks, in touch with your long-term health team can be very helpful.
Great, thank you. Does anyone else have anything that they'd like to add?
Yeah, it wouldn't hurt to bring some written patient information material. We have a brochure that somebody showed earlier, the one at the, I think the AES website, or is it epilepsy.com? Probably both. Have a sheet, a fact sheet on psychogenic non-epileptic seizures. And so maybe you can share that with the providers that don't understand it.
Okay. So I'd like to add that for tomorrow, there are a couple breakout rooms that we're going to be using to discuss recommendations for navigating healthcare and treatment, as well as discussing patients who will share their experiencing and advocating with clinicians for themselves. Let's see. So at this time, I'd like to thank the doctors. Honestly, this has been such a great discussion. I've really enjoyed it and learned a lot. I hope everyone else has. Thanks for putting up with my questions.